reading that we use for prostate cancer, they tend to have the higher grades of Gleason score, meaning the cancer seems to be aggressive in this particular population. They have 1.8 more chance of being diagnosed with prostate cancer and about 2.2 times more chance of dying because of prostate cancer. Unfortunately, there is a lot of treatment disparities. So this particular group of people, they're less likely to be treated compared to white population in the US. About 27% of African Americans tend to not get the care they need. It similarly applies to Hispanic patients too. If you look at Medicare itself in patients who are above 65 years of age who come for care, about 11% of African Americans have prostate cancer. But this is just the tip of the iceberg. There are more number of people who need care and they're not having care right access at the right time. Now, the biggest problem with prostate cancer is, as clinicians, they're asymptomatic. So patients do not have symptoms. They're symptomatic only when it's advanced, when it's metastatic. That's when they have either bony pain or they have problems because of an enlarged prostate over a long time where they could have obstructed system leading to uremia. It's pretty easy to actually diagnose prostate cancer. The screening for prostate cancer involves just a rectal exam and do a blood test called PSA. Now, to screen or not to screen is the biggest debate that we have among medical faculty, among prominent urologists. That's an ongoing debate. Uh, so the guys who are actually proponents of screening, they say it's easy to implement, it's just a blood test, it's pretty reliable, and it's cheap. But people who are against screening, they there's a risk of overdiagnosis and undertreatment. Sorry. Now with the PSA, the traditional cutoff is about 4, but about 15% of our cancers are not detected because they tend to occur in patients who have PSA less than 4. Now, what is the cutoff? So that's another debate that's on. Clinically, what we look at is the trend in PSA. If there is a sudden jump in PSA, then your patients need to be screened earlier and, for prostate cancer, and if found, they should be treated earlier. I mean, in fact, if you look at the levels of PSA, even if PSA is less than 0.5, there's 0.8% risk of having high-grade tumors. So in 2012, the US task force, they recommended against PSA screening. This was a major step, which was kind of detrimental to our population. This recommendation was followed by a lot of family physicians. And after this recommendation, we started seeing more high-grade tumors coming to our practice, people with more advanced disease. Even for the biopsy, when they get diagnosed after the biopsy, they tend to have like high-grade tumors of Gleason 8 and 9 and with widespread disease. They realized their mistake in 2018. They again went back in recommending screening because there was a flurry of reports suggesting that people tend to have higher grade tumors because of lack of screening. In our own practice, we looked at the trends of patients who were being referred to us. We are a large practice with about 14,000 prostatectomies under our belt. And we looked at trends. If you look at this particular slide, after 2013, we saw an increase in Gleason score of 4+3 and 4+4, meaning more high-grade tumors were diagnosed just because of one recommendation by the task force. And as a result of it, we also had locally advanced tumor. This is T3 disease is locally advanced tumor, and T4 disease is when it's involving other surrounding organs. So we saw an increase in trend of locally advanced disease, and T2 disease is a localized disease, and we saw a reduction in the number of T2 disease. So that's why it's important to screen. And once we screen and we suspect prostate cancer, it's fairly easy to diagnose prostate cancer. We just have to do a biopsy of the prostate. Traditionally, we use the transrectal ultrasound to do the biopsy of the prostate. This is a probe that is passed through the rectum, and then we can take multiple samples from the prostate. Currently, we do an advanced form of biopsy called the MRI fusion biopsy. This is our machine that we use. So what this machine does is the patient has an MRI scan before the biopsy, and it kind of superimposes the MRI over the ultrasound images. So the ultrasound images are real time ultrasound images, and the MRI images are superimposed over it. This helps us in targeting lesions better, targeting the prostate, in fact, better, and increases the yield of prostate tissue, leading to more chance of detecting prostate cancer. So on an MRI, the radiologist gives us a score called the PIRAT score. PIRATs 1 and 2 are low-grade lesions that do not indicate anything, meaning that they're unlikely being cancerous. Uh, the PIRATs 3 is somewhere in the middle. It could be, it could not be. And PIRATs 4 and 5 indicate high-grade tumors. So these are the lesions that need to be biopsied on the MRI. So this is how it's done, where the MRI images are fused and then the machine generates a 3D model. It's about 2 to 3 times more sensitive compared to the regular biopsy. Now, the treatment options for prostate cancer, when it's clinically significant, would be either surgery or radiation. We offer surgical treatment over here. Uh, Again, we primarily do the robotic prostatectomy. So over time, the treatment has moved on from traditional open surgeries to using more advanced technology like the robotic systems. You would see the advantage of robotic system in the subsequent slides. So if you see in the US alone, since 2003, the number of robotic prostatectomies have gone up while open prostatectomies have gone down. I mean, it's just goes to show that how convenient this particular procedure is using the robot and how good is the outcome. So 20 years back, this is what you would have probably used. It's our good old Da Vinci system. It's a standard system. Uh, but over time, the number of systems have changed. We have more advanced technology. We started off with Da Vinci Standard, went on to S, to SI, XI, and currently we have the SP. This is a single port system that helps us to do the surgery using a single keyhole. Now, as the robotic systems improved, we adapted our technique. Uh, we made changes to the way we do the surgeries. We introduced newer techniques that helps us in improving the outcomes after prostatectomy. So this is the latest Da Vinci single port system. If you see, all the instruments come out through a single port, and then they are articulated at the tip. That helps us in doing the surgery more precisely. So this is how traditionally the surgery would have been done, such a big scar almost extending from your navel down to the pubic bone. And this is the standard robotic system where you have 6 incisions. And this is the Da Vinci system. So this is how we've evolved over time. Now we can take out prostate through a single small tiny hole, which is about 3 centimeters in size. The biggest problem of this particular procedure is incontinence, where people tend to have urinary leaks for about 6 to 8 weeks after the surgery, and then impotency. They tend to have erectile dysfunction for about a year after the surgery. This happens because of this particular anatomy. So this is your prostate. Sorry, I'm having some issues with the presentation. So this is the prostate. So when we remove the prostate, the internal sphincter of the bladder lies over here, and the external sphincter lies somewhere here between the bone over here. So we lose the internal sphincter after prostatectomy. That's the reason why patients tend to have incontinence. It's a part of the procedure where we excise the prostate along with the internal sphincter. So they need to work on their external sphincter so they get good continence. And the impotency happens because the neurovascular bundle, they travel along in between your rectum and the prostate. This is your rectum over here and the prostate over here. They travel along like this path to the penis. So there is a chance that you could injure these neurovascular bundle. So robotic surgery helps us to do more precise surgeries, and we can kind of preserve these neurovascular bundle provided the cancer lets us do. Over these years, we've made all these modifications to our surgery. The first picture is a DVC suspension stitch. So this stitch helps us to actually tuck the urethra up. This helps us in increasing the continence level. This is the picture on the right shows the nerve sparing, where this is the neurovascular bundle on the left-hand side, and this is the prostate. We try and preserve this. Again, the caveat is the cancer should be localized when it's within the prostate. We get good outcomes because we are able to do all these maneuvers. But if it's outside the prostate, then we have to excise this neurovascular bundle. So another modification that we used after we had the excise system is the toggle up, where we can look from underneath the prostate. So this is the prostatic artery over here. That is a landmark for the neurovascular bundle. So it helps us again in preserving the neurovascular bundle. And this is something called a Rocco stitch that helps us in buttressing our anastomosis. After we remove the prostate, we sew our bladder back to the urethra. And this kind of supports the anastomosis and helps in getting early continence. So I'll just show you a small clip as to, it tells us how precise the surgery is. Sorry again. So playing the video. Yep. I'm having some trouble with the video. Just a sec. The play is here. See. Yeah. I'm sorry about that. I had some issue with the video. So we have 10 times magnification. We have fine instruments. These instruments are wristed. They have 7 degrees of motion. With such good visualization and with such precise instruments, we're able to perform a meticulous dissection and a meticulous operation. So this is our regular XI robot. The SP is even more articulated. It's the instruments are, you have both the arm and the instruments have a shoulder. So it gives us more degree of motion, and it can be done in a single keyhole, which is about 3 centimeters in size. I'll just try and skip through this. Right. So when we look at prostate cancer after the surgery, there are a few parameters that decide how the patients do, what's the chances of cure rate. One is the Gleason score of the prostate. The other is the extent of the tumor. The third is whether lymph nodes are involved or not with cancer. The fourth is our surgical margins. If our surgical margins are clear, then the chances of outcomes are better. And the fifth is involvement of the extracapsular extension, meaning the prostate has a capsule around it, if the tumor is extending beyond the capsule of the prostate or not. We use the PSA for follow-up. Ideally, it has to be undetectable, but if we find PSA after the surgery in a patient, then we have to investigate further and see if they have any other sites with prostate cancer. So when we looked at our own series of 7,000 patients, about 10% of our patients had cancer recurrence, but 90% of our patients were cured after the surgery. When we looked at our continence rates, we had relatively good continence rate. About 96% of our patients didn't have any issues in continence. They were pad-free at the end of a year. So currently in the literature, the likelihood of patients needing pads after surgery is about 70% 6 weeks after the surgery and about 20% 6 months later. In our series, it was about 56% 6 weeks after the surgery and about 17% 6 months later. So the potency is probably the Achilles tendon of this procedure, meaning that is unpredictable. There are many factors that decide potency. One is the nerve sparing, that is probably the only modifiable factor that's in hands of the surgeon. But the baseline sexual function, the age of the patient, the surgeon's technique and experience, all these factors affect potency. Now, when we looked at our whole data, our potency rates, it's a wide range of potency, but rates ranges from 54% to 90%. The reason being, again, like I said, there are many factors that would decide potency. But in an ideal patient who's potent preoperatively, who has a localized prostate cancer, when we do a good nerve sparing, about 90% of our patients tend to have potency after the surgery. So this is important for us. This is probably the only thing that we discuss with our patients when they come to us in detail, telling them, they kind of expect that robotic surgery would preserve everything, but we tell them that potency might be an issue at the end of the day. But the other two are some things that we can actually give you a good outcome. So the take-home message is you need to screen. We believe in screening. Once we diagnose early and if we treat at the right time, the patient should do well. Thank you. Now I should be able to take some questions if anybody has some questions.
One of the questions someone has for you, Dr. Bhat, is what level of testosterone triggers the prostate cancer?
So there is no particular level. Actually, there are diverse papers. Even low testosterone can cause prostate cancer, or high testosterone can cause prostate cancer. As long as the patient's testosterone level is within the normal range, he is protected from prostate cancer. So recently there was a paper in BJUI last year that told us that, if patients tend to have testosterone deficiency, they have a higher risk of having high-grade tumors. So that is something that is being studied. Until 2 years back, people would say, okay, high levels of testosterone can cause prostate cancer. But now we've found both low and high can do. As long as your testosterone level is within the normal range, you should have, you should be protected from prostate cancer. So in patients who have androgen deficiency, we should supplement testosterone. People, if they have high testosterone, it's most likely exogenous. They are taking testosterone supplements and they need to cut down on that.
Another question from the audience, Dr. Bhat, is what causes testosterone levels to be low or high, and what foods maintain testosterone levels?
So the cause for testosterone androgen deficiency, it could be endogenous or exogenous, right? Endogenous being your body doesn't produce testosterone. There are multiple reasons. Testicular failure can cause testosterone. Pituitary tumors can cause your testosterone to go down, right? The exogenous causes are usually radiation for testicular cancer, or orchidectomy can cause, or chemotherapy drugs can cause testosterone deficiency. So there are multiple factors, which could cause testosterone deficiency. Again, the testosterone to go up could be tumors, testicular tumors. Some are embryonal, functioning testicular tumors can cause high levels of testosterone, or if the patient is taking supplements.
Thank you. And another question from the audience is, does diabetes increase the risk of prostate cancer?
So diabetes has been linked with benign prostatic hyperplasia. As far as I know, there is no direct link with diabetes and prostate cancer. It's more of a benign enlargement of prostate. But yes, diabetic patients can have multiple episodes of prostatitis, and there are anecdotal evidence linking prostatitis with prostate cancer. But metformin is known to be protective for prostate cancer. So metformin is an anti-diabetic medication that's known to protect people from prostate cancer. That's a part of our STAMPEDE trial. They have actually added an arm. They're evaluating use of metformin in prostate cancer.
Thank you. And another question is from the audience, can you comment more on the folic acid and vitamin E contribution to prostate cancer?
So the strongest evidence for vitamin E is the SELECT trial. It's a randomized controlled trial, and they found that there is increased risk of prostate cancer, but it was not reproducible. Subsequent trials did not tell us that vitamin E is actually going to lead to prostate cancer. But still, if you go by the SELECT trial, that is linked to prostate cancer. Folic acid, again, there is no strong evidence, no level 1 evidence to suggest that folic acid is linked to prostate cancer.
What about
The
calcium?
SELECT trial had the selenium and vitamin E as either selenium was one arm, selenium plus vitamin E was the other arm.
Sorry, someone had asked, what about calcium?
Yeah, I told you about dairy products and calcium have been linked with prostate cancer. Again, these are all not level 1 evidence yet.
There is another question in the chat. What is the function of prostaglandins to prostate cancer?
I'm not aware of that. I'll have to look up if prostaglandins. So prostaglandins with prostate cancer, I'll have to look at specific association between those.
How do you generate a pyrade score prior to biopsy?
So it's usually based on, the intensity that the radiologist looks at in T2 weighted images and DWI. So the original PIRAT score looked at DWI images, T2 weighted images, the spectroscopy images, and then the radiologist would give a score. But with the PIRATS 2.1, I think they use the DWI for transitional zone and the T2 weighted images for the peripheral zone of the prostate. And they're looking at hypointense areas in them as lesions, and hyper in T2 weighted images, and hyperintense areas as lesions in DWI. And then they give a score based on that. So if you want more details, I think radiologists would be able to give you about that.
Hi, doctor. I'm Dr. Lowe, and I think they gave me permission to speak. I wasn't so clear about what you're saying about supplements. You're saying that too much folic acid and too much E,
yeah,
there is a problem.
yes.
But what about that vitamin D thing? Everybody seems to think nowadays that nearly for all cancers, especially D, and out here certainly the D seems to help. Is that so? Not so?
Yes. So the idea of calcium supplementation, the reason why they said calcium leads to prostate cancer, it decreases vitamin D in your body and causes prostate cancer. So that was the relationship when they initially hypothesized. And there are many papers on vitamin D deficiency leading to both prostatitis as a separate disease entity and prostate cancer too. Okay. I don't know exact percentages of the literature, but I've read some reports suggesting that vitamin D deficiency leads to prostate cancer too.
Okay, thank you, sir.
Yeah.
We have another question in the chat. What is the most accurate test for the prostate cancer?
If you're able to answer that question, you will get the Nobel Prize. So the biopsy is the test for prostate cancer, period. So biopsy is the confirmatory test. So it's an invasive procedure. There are multiple investigation blood tests, including PSA. There are derivatives of PSA, free PSA, PSA density, PSA velocity. Among all these derivatives, PSA density seems to have higher association with the diagnosis of clinical significant prostate cancer. There were other combinations of these, the both free and total PSA, like the PHI, Prostatic Health Index, and the OPCO 4K test. But at best, they have the area under curve of about 0.78, if I'm not mistaken. The biopsy is 100% specific, right? The sensitivity depends on the kind of biopsy done. So there is section biopsy, which is just taking 6 cores. There is saturation biopsy, where they take 24 cores and above. There is MRI fusion biopsy, which has the sensitivity of MRI fusion biopsy is almost 85 to 90%. So if you want a confirmatory test, it's an invasive procedure rather than any of the other tests. There are many tests like PCA3, which is it's called the commercially available kit is called the exosome. That is a test that is done in urine, where they look for the PCA3 expression and they give you a value. There are other tests that would tell us if patient, tests could be used for many things. One is for diagnosis, one is for prognostication. There are many genetic tests for prognostication too.
Okay, we have a couple more questions coming from the chat. The first one is, when is the best age that men should start screening for the cancer?
Right. So according to the European Association of Urology, 50 is the age for screening for prostate cancer. But if a patient has a strong family history, meaning 2 or more family members having prostate cancer, people of African American heritage, those who are having, like, say, if they've diagnosed with genetic mutation like BRCA, they should be screened at the age of 40 for prostate cancer. The screening would involve doing a blood test called PSA, and then doing a rectal exam. Again, once a year screening is recommended up to the age of 70, after which, again, it can be offered to the patient. I mean, there are, so the EAU says after 70 years, you may or may not offer screening for patients. Again, there are, I mean, practice would change. We would offer patients, if they want, they can get screened after 70 as well.
Okay, thank you so much. And another question. So the increased precision of the robotics has improved the potency and incontinence issue. Yes, well, how well did it improve? What's the percentage? Sorry, if the person, sorry.
So in 2012, there was a systematic review and meta-analysis that was published by a group in Italy. So that is the strongest evidence that we have supporting robotic prostatectomy versus an open procedure. So their endpoints were something called a trifecta. So trifecta would be cancer control, continence, and potency. So there wasn't any difference between cancer control and continence. They were pretty much same. But potency rate, yes, they changed because of, again, nerve sparing. I think at that point of time, they were looking at only patients who were preoperatively potent and localized prostate cancer with a good nerve sparing. And the rates of potency described with robotic prostatectomy was about 92%, and with open prostatectomy was about, I think, 70% in that particular analysis. But there are many reports after that since then.
Okay, so I have another question coming in. So how exactly are the dairy products linked with the prostate cancer? Like, what is the correlation? Why is there a correlation?
I told you, I mean, I think the dairy product, what they mean is the stipulated hypothesis is that it increases the dihydrotestosterone, and it's supposed to be linked with dairy products increasing dihydrotestosterone levels in the body by altering the, I think, 125 hydroxylase pathway, right? And then that will lead to increased prostate cancer. Now, dairy products would be milk, yogurt, etc. I'm not exactly sure what other products are involved with prostate cancer.
Perfect. All right. Thanks for the great talk, Dr. Bhat. Another question. Are there studies that explain the genetic contributions that are the basis of the differences between different populations, such as African Americans?
There have been many studies on genetics and prostate cancer. There are a lot of papers on that. I probably wouldn't off the head be able to tell you exactly which genes with African Americans. I think it is the TMPRSS gene and the ERG gene that were linked with this particular population. I'll have to look up and get back to you on that.
Okay, and could the nutritional information you mentioned help improve these racial and ethnic differences, do you think?
I think what would make a difference is access to healthcare and screening in this particular population. That will make a lot of difference.
Perfect. Thank you so much. I don't think there are any more questions. So back to you, Dr. Fletcher.
Right.
Well, thank you so much, Dr.
for
Bhat.
having me here.